The great majority of appendices are reached satisfactorily through the right lower muscle-splitting incision. The incision is made at McBurney's point, which sits one-third of the way along an imaginary line drawn from the right anterior superior iliac spine to the umbilicus. Wherever the incision is, it is deepened first to the aponeurosis of the outer layer of muscle. In the muscle-splitting incision, the aponeurosis of the external oblique is split from the edge of the rectus sheath out into the flank, parallel to its fibers. With the external oblique held aside by retractors, the internal oblique muscle is split parallel to its fibers up to the rectus sheath and laterally toward the iliac crest. Sometimes the transversalis fascia and muscle are divided with the internal oblique, but a stouter structure or repair results if the transversalis fascia is opened with the peritoneum. The peritoneum is picked up between forceps, first by the operator and then by the assistant. The operator drops the original bite, picks it up again close to the forceps of the first assistant, and compresses the peritoneum between the forceps with the handle of the scalpel to free the underlying intestine. This maneuver to safeguard the bowel is important and should always be carried out before opening the peritoneum. As soon as the peritoneum is opened, the abdominal wall structures are protected with gauze pads to minimize any potential contamination. The edges of the peritoneum are then clamped to the moist gauze sponges already surrounding the wound. Cultures are taken of the peritoneal fluid. The right angle clamp is moved 1 centimeter toward the tip of the appendix. Just at the proximal edge of the crushed portion, the appendix is ligated. A purse string suture is laid in the wall of the cecum at the base of the appendix, care being taken not to perforate blood vessels where the mesentery of the appendix was attached. The appendix is held upward, the cecum is walled off with moist gauze to prevent contamination, and the appendix is divided between the ligature and clamp. The suture on the base of the appendix is cut and pushed inward with the straight clamp on the ligature of the stump to invaginate the stump into the cecal wall. The jaws of the clamp are separated, and the clamp is removed as the purse string suture is tied. The area is lavaged with warm saline and the omentum is placed over the site of operation. If there has been a localized abscess or a perforation near the base so that a secure closure of the cecum is not possible, or if hemostasis has been poor, drainage may be advisable. The muscle layers are held apart while the peritoneum is closed with a running or interrupted absorbable suture. Interrupted sutures are placed in the internal oblique muscle. The external oblique aponeurosis is closed but not constricted with interrupted sutures. The subcutaneous tissue and skin are closed in layers.